So this also correlated with a much lower cumulative dosing of corticosteroids, which is very important in children in their growth, and is a suggestion that you can improve the outcomes if you intervene very early in the course of disease. We also have data with anti-TNFs looking in post hoc analyses from these maintenance studies that the shorter the time from diagnosis, the higher the response or remission rate. In this look at the CHARM data with adalimumab, you can see that patients who had been diagnosed less than 2 years before had a 59% remission rate compared to 40% in patients 2 or more years out from their diagnosis. And likewise, if you look in the PRECISE-2 study, which was certolizumab Pegol maintenance dosing, you can see that diagnosed less than 1 year, you have a 68% remission rate. And if you were included in the study more than 5 years out from your diagnosis, this dropped to 44%. You don't see much of a change, maybe some, in the placebo response rate. And this thinking led to a very important, but still, I would say, very preliminary study looking at a comparison of early aggressive biologic therapy to conventional management of Crohn's disease, the so-called StepUp TopDown study. We heard about this at DDWs repeatedly for a number of years, and finally last year it made it to full publication for all of us to look at the data. This was an open-label study where patients, essentially all of them, were within 1 year of diagnosis except for 4 patients, but none of them had previously been exposed to antimetabolite therapy, to anti-TNF. None of them had received steroids before. And the patients assigned to conventional therapy were given a steroid taper. If they failed this taper, they got a second steroid taper, and then finally failing that, they were put on an antimetabolite, either azathioprine or methotrexate if they didn't tolerate that. And then finally failing that, they would eventually see infliximab. The early aggressive arm was assigned to get infliximab induction therapy, just 3 induction doses, simultaneously to start azathioprine. And then they didn't get any further infliximab unless they had a flare through their azathioprine. They would get additional episodic dosing of infliximab, and failing that, they would finally get steroids. So here are the results. Looking at 6 months and at 12 months, looking at this fairly stringent endpoint of being in remission without steroids and without having needed surgical resection, there was a statistically significant difference, and I would say a very clinically meaningful difference in the patients who got early aggressive therapy compared to the conventional step-up therapy. And this difference was fairly large, 25% or so.
But Bruce, I have to say, their initial design of the study, 1 arm was placed on steroids, 2 courses of steroids.
That's right.
Based on Fabian's data, about 33% of those people are going to be steroid dependent and are not going to meet the endpoint.
That's right.
So
and that was
a 33% bias against 1 arm.
And that's exactly why the study was not published for so many years, because I think every reviewer has said the same thing. In other words, if your primary endpoint includes the need for steroids and you required 1 arm to have steroids, you're really kind of biasing against 1 arm. But I'll show you other data to suggest that this is still an important result. Now, so at 1 year, this was a significant difference. But beyond 1 year, actually, these lines converged. The outcomes really became very similar after 1 year. So you could argue, well, what's the use of early aggressive therapy, early biologic therapy? After a year, they look the same anyhow. It's important to realize that even though this was a step-up therapy, by 1 year, more than 70% of patients were on an immune-suppressing agent. One wonders if you had another arm and everyone were put on azathioprine from the get-go, would the outcomes be very similar? We don't know. I think the most impressive thing about this study, though, is this result, which showed that in a subgroup of patients who got colonoscopy at year 2, you could see complete healing of the mucosa 2 years out in 73% of the patients who got early aggressive biologic therapy and then azathioprine, compared to only 30% who were assigned to conventional therapy. Now, this is far from saying that this will result in fewer surgeries, but we do believe that mucosal healing will be correlated with subsequent outcomes. This was statistically highly significant, and I think the most impressive thing is to realize that since by 2 years most patients were on azathioprine, most of this effect is probably carryover effect from the initial induction dosing of three doses of infliximab. And to get to your point, Peter, if you take out of the mix the first 14 weeks where everyone had to be on steroids, and you look at it just from week 14 through 2 years, and you say even more stringently that patient had to have been in remission not at 2 years, but for the whole time from week 14 to 2 years, had to have discontinued steroids and infliximab and never used these things again over 2 years and had not had a surgery, you still see a huge difference, 24% difference between early aggressive and conventional. So I think these data are very meaningful, but again, it's an open label study. You can understand why they did this in an open label way. It's very difficult to randomize patients to complicated treatment regimens and keep everyone blinded for 2 years. But it's important data nevertheless. By comparison, a somewhat more experienced group of patients who had been around the block with Crohn's disease have a different look. So these are not newly diagnosed patients who had similarly induction dosing with infliximab. All of them were put on azathioprine or 6-MP at the beginning of randomization. And initially you can see that those 3 doses of infliximab do very nicely, but over a year the lines converge. It's still statistically significant, but when you look out more than a year, everything looks the same. So if you've failed azathioprine, very likely just induction dosing with infliximab is not going to be enough to maintain you over the long term. So if early aggressive therapy, if we agree that it may be effective, it may improve the outcomes, why would we not treat every patient in this way? Well, apart from the cost of treating every patient with a biologic agent, there are certainly other reasons, and mainly it's concern over the safety of anti-TNF agents. You are probably all familiar with these warnings and data. Hypersensitivity reactions usually are not a reason why patients will need to stop an agent. It's usually loss of response related to antibodies to the drug. There are also autoimmune phenomenon, newly positive ANA in roughly 40% of patients exposed to infliximab, lower rates in patients with certolizumab pegol exposure. Lupus-like reactions, however, are quite rare. TB, serious infections, histoplasmosis. Do you see histoplasmosis in Michigan?
Fortunately not.
You don't. We don't see it either, but there are places very close to both of where we live where this is a problem. Hematologic toxicity is uncommon. If the patient has moderate CHF, this is a relatively strong contraindication to an anti-TNF agent where you do see an increased mortality rate. But I think the things that really concern us are malignancy, especially lymphoma, including hepatosplenic T-cell lymphoma, which is very rare, 18 reported cases with anti-TNF antibody use of various sorts. And we worry about the infections. There's also rare demyelinating disorders of multiple sclerosis-like illness, peripheral neuropathies, liver failure, and so on. But again, the main concerns are malignancy, especially lymphoma, and infection risk. So what are the data there? We do have data from a prospective registry called the TREAT registry. This was sort of a cohort of convenience. These were not consecutive patients. We don't know exactly how the patients were selected. These were combinations of academic medical centers and community practices enrolling patients who were either exposed or not exposed to infliximab. And in multivariate analyses, the things that predicted serious infection and mortality were not exposure to infliximab, not exposure to immune modulators, but rather the current use of corticosteroids and, interestingly, current use of narcotic analgesics. I'm not entirely sure how to understand this one, except that this is a marker for more severe disease, more symptomatic disease.